Welcome to my weekly podcast, Inspiring Each Other. I'm Dr. Phil Worth, and tonight I'm here with Dr. Kristin Baltazar, a local surgeon at Finger Lakes Health, and her patient Kaylee Stone. And we're here in honor of Breast Cancer Awareness Month to talk about these wonderful women's journey with breast cancer. Ladies, welcome to the podcast.
Thank you.
Thank you for having us.
Kaylee, I have the pleasure of talking to people all the time and saying, Mrs. Smith, I'm sorry, I think I see a lump. Mrs. Smith, I think there's a spot on your lungs. And when those words leave my mouth, I get the sense that they can be life-changing and identity-changing for people. Can you tell me a little bit about that part of your journey?
That is 100% true. My journey was a little bit different. I found my lump myself at home. I was in the shower. I was only 30 years old, drying off, and felt something different. I had reached out to my doctor right away, and within 2 weeks, I was diagnosed with breast cancer. I wouldn't have had a mammogram for another 10 years if I hadn't found it. So,
Dr. B, is that a common story, would you say?
I think it's common in the younger patient population for exactly the reason that Kaylee mentioned. You know, all of our studies have really pointed to the efficacy of screening mammography in patients at average risk to start at age 40. And so we're not necessarily screening the 30-year-old or the 25-year-old even. And unfortunately, as a society, and for reasons unknown, we are definitely seeing breast cancer in younger and younger patients. So anecdotally, I don't think that's enough to change our screening recommendations yet, but it may in the future.
I think, when we talk about, in my world, the self-clinical breast exam, right? When you read about a self-breast exam, geez, we shouldn't, it doesn't help, right? Is what you read about in some of these guidelines. Everyone that I've ever had in Kaylee's age group has come into me and said, hey, I kind of found something, right? And so do you have that same experience?
I do. I think in the younger age group, self-exams are very, very important. In the women who are getting screening mammography annually, if they find a lump, then we haven't done our job, because the limits of our detection of mammogram now with 3D mammography, we can find tumors that are 2 and 3 millimeters, and that's not something that someone would ever be able to feel on a self-exam.
Tell me a little bit about your journey. How did you decide you wanted to be a surgeon, and what made you say, geez, I kind of like breast cancer surgery? How did you end up there?
As far as becoming a surgeon, it was sort of by default. I went to medical school wanting to be a pediatrician, and had a notion in my head that I did not want to be a surgeon because there was a lot of misconceptions about rigorous training, not necessarily a field that embraces women physicians, et cetera, et cetera. So when it came time to do my clinical rotations as a third-year medical student, I chose to do surgery first with the intention of I just want to get it out of the way. And within 3 days, I fell in love with surgery. So the ability to see someone who is sick or injured or hurt and know that you have the power to fix them and make them whole again is unique to surgery and surgical subspecialties. And I just loved the instant gratification of it. I'm less patient than I thought I was 20 years ago.
For me, it was a similar story in that my first rotation was surgery. And I was working with a group of the general surgeons at Rochester General. And I'd been there for 4 or 5 weeks, and I'm sewing things up, and I'm like, I'm a rock star. I think, I'm pretty sure I want to be a surgeon. And then in comes this young female PA student. And they say, Phil, can you help her close this up? Can you show her? And I show her. And this girl just whipped through this thing like it was nobody's business. And after that case, my mentor, right, the surgical guy, was like, Phil, you probably shouldn't do surgery. Did you see how quick she just learned how to do that? Your hands are terrible. And so I have so much respect for people that can do things with their hands, because I can't. Right. And it's nice that we all have different qualities so we can help people like Kaylee. Kaylee, walk me through your journey a little bit. So you find this thing, you get diagnosed with breast cancer. Walk me through it.
for sure. I had an appointment set up with Dr. Baltazar before I even got the definite result of, yes, you have breast cancer. I was supposed to see her the next morning. I got the phone call from my OBGYN at the time with the words, I'm sorry to tell you, you have breast cancer. It was the worst day of my life. My husband was there with me. We called my dad. Dad came over, came to the rescue like he always does, cried with us on the floor and said, okay, you're going to get up and you're going to do what you got to do. And my dad was with me every step of the way, every appointment, every treatment.
And then you see Dr. B the next day.
The next morning, I met this angel. My whole family came with me. My brother flew home that same night. My best friend, my cousin, my husband, my dad, my support system. They were with me from day one. And not only did Dr. Baltazar become a huge part of my life that day, she became a huge part of their lives as well. She sat with them as a group and talked to them separately from me to make sure they were okay as well. And that made such a difference in our lives.
It the same surgeon that I mentioned to me asked me a question when I was training, and he said, Phil, what's the most important thing in medicine? And I'm thinking of fancy stuff. And he said, talk to your patients and listen to your patients. And Dr. B, I've heard that over and over and over again about you. Is that a trait that you developed? Is it just something that's who you were growing up and getting into surgery?
I think it's probably a combination of the two. Inherently, I always aspired to be the kind of doctor that listened to their patients. I never wanted to be the person that had a negative reputation or who people didn't feel comfortable talking to me. Because if your patients aren't comfortable with you, it doesn't make for a good experience for them. It doesn't make for a good outcome for them. And so part of that, I think, is just my inherent personality. I have a big heart and I care. And part of that is, particularly when my breast cancer patients, with every woman that I see that's diagnosed with breast cancer, I am walking that journey with them. And it's a privilege and an honor. And that's very humbling, but it also inspires you to do better as a physician. So to me, it's been both a combination of my personality and the things that I learned from my patients.
It's I couldn't agree more. Kaylee, as you get started talking about this, how does it go? What does Dr. B say to you? Where do we go from here, right? What's the next parts for you?
I'll never forget her sitting with my husband and I in that room that day, saying breast cancer is going to become a part of your life, but don't let it take over your life. And from that day on, we just held our head high, stayed positive, and did what we had to do. Went through treatment.
Walk me through the treatment part, right?
Treatment. I went through chemotherapy, followed by surgery, and then radiation. It was a pretty rough go. Chemo was pretty rough. I went through that for 3 months, I think it was. And it was trying. It was very trying. My dad sat with me at every treatment. There were long days, there were hard days, there were sick days.
Chemotherapy is a little different now than it was 20 or 30 years ago when I trained. God, we're getting old, right? Back then we used to think of it as we are trying to kill all of your cells and we're hoping we kill the cancer cells first, right? That was kind of the mantra, and there was so much toxicity to chemotherapy, much more than there is with some of the newer stuff today. What were some of the negatives of the chemotherapy that you went through?
The hardest part of the chemotherapy was the hair loss for me. As a 30-year-old woman, that's a huge part of your identity. And I'll never forget meeting my oncologist that first day, and they had told me, usually within 2 weeks, you'll start to lose your hair. I broke down. It was 2 weeks to the day. Started losing my hair. So we had a good cry about it. I called my dad again. He came over and I made him shave my head. We shaved my head and it was almost liberating. And from that day on, we said, okay, we're going to stay positive about this.
It's there was certainly a letting go, right, of that experience. Dr. Baltazar, looking back, right, there's lots of different ways that we treat cancer now, right? I don't even know anything about it anymore, right? So it's a whole new world for me. I rely on you guys to coach us through. Talk about some of the different ways that we treat this, and why, in Kaylee's instance, did we start with chemotherapy?
Sure. So even you say 20 to 30 years ago, our chemo drugs have changed. 5 years ago, our chemo drugs have changed. And so the way that I treat breast cancer in 2024 is not the same way I did 5 years ago, which is a good thing. There really are kind of four mainstays of treatment for breast cancer. For early stage breast cancer, surgery is the main form of treatment. We also use chemotherapy, as Kaylee talked about. We also use radiation therapy sometimes, and then some oral therapy, so medications that patients take to reduce their risk of breast cancer recurrence. And now, within the last 5 years, the focus has been on immunotherapy, so drugs that are targeted to treat specific subtypes of breast cancer. And breast cancer is a catch-all term for a million different diseases, and I tell that to every patient, that your tumor is not like anybody else's, and therefore your treatment may not be like anybody else's. So I think when patients hear the word breast cancer, that term can encompass something very small that is going to be taken care of with surgery and you don't need any further treatment, or that term can mean something very large that has already spread, and you're going to require all of those things that I just talked about to treat it. And so nowadays, the decision to treat with chemotherapy can occur before surgery or it can occur after surgery. And so in Kaylee's specific case, she had evidence of spread to a lymph node at the time of her diagnosis, and she had a very large tumor relative to the size of her breast. And so in those cases, we almost always treat with chemotherapy before surgery in order to make the likelihood of surgery more successful, so to allow us to actually remove all of the gross cancer cells at the time of surgery. It also gives us some predictability about prognosis. So patients who have a good response to chemo, meaning that their tumor shrinks in a finite amount of time, those patients tend to do a little bit better. And so we're not necessarily less aggressive with treating their tumors. It just lets us know how we should be treating them after surgery.
Kaylee, it's been 7 years.
7 years.
So with what? First of all, congratulations,
Thank
ladies.
you.
Great job. That's
We're getting
awesome.
old.
Thank you. It's a good thing.
Dr. B, if you look back, would Kaylee's treatment be different today than it was 7 years ago? Are there enough new things out there now with her specific type of breast cancer? Would it be a different road that someone had to walk through?
So the only thing that Kaylee may have gotten differently is immunotherapy, which really was not standard of care 7 years ago. But obviously she's doing great. And statistically, when you have breast cancer, regardless of the subtype, your recurrence rate goes down after you make it 2 years without a recurrence. It goes down again at 5 years, and it goes down again at 10 years. So she's had two major milestones since her diagnosis and treatment.
That's awesome.
It's amazing.
So we've had the chemo, and that beat the bejesus out of you. You started to look like me.
Yeah, it did.
And now, thank you for all that. Now we're going to cut your breast. Walk me through that part of it.
With the help of Dr. Baltazar and my oncologist, Dr. Ignatiak, they had both come to the conclusion that it would be the best for me to just have a lumpectomy at the time because of the way I responded to chemotherapy and the size. Everything was great. I trusted their judgment, and I'm so thankful I did. I did not have to have a mastectomy, and I'm so thankful for that. So yeah, that was the next step.
So talk a little bit about that. There's a lump, and you go in and cut this thing out in a couple hours. Genius that you are, right? What helps you make that decision is, because I've heard some women come in and go, just take them all off. I'm done. I don't want any of them. I'll get implants later. And other people, how do you help someone make that decision?
So I always tell my patients in that conversation, my job is to educate you. My job is to guide you toward what is right from a medical standpoint, but it's a very personal decision. So in some cases, the decision is made by the characteristics of the tumor. Sometimes a lumpectomy is not feasible. If the tumor is very large, if it's invading surrounding structures, if it's certain subtypes of cancer, we recommend more aggressive surgery than others. And that's an easy conversation because there's only one option. It's very easy for me to say, this is what I recommend based on X, Y, and Z. For most women who have early stage breast cancer, either option, mastectomy, which is removing the entire breast and the nipple and the areola, or lumpectomy, which is removing the tumor and some of the healthy surrounding breast tissue but leaving the breast intact, is an option. And so I always give patients that option. And just like you said, women are either one side or the other. They do not want to lose their breasts no matter what, or they don't want to deal with the possibility of having mammograms and MRIs and ultrasounds every year, and they just want to have a mastectomy. And obviously with the news publicizing some of the celebrities that have undergone bilateral mastectomy, that is an option as well. Not for everybody, but in the right patient population, it's a great operation.
Kaylee, as you went through this, excuse me, did you feel like that was what happened, right? You had an education, you thought about it, and then you came up with a choice that felt right for you?
Absolutely. From day one, I was educated from day one, and I trusted these guys with my life. And their judgment meant the world to me, and I agreed 100%.
We finished that part. You're healing up. Are there any bumps? Is your healing up and this thing is doing what it's supposed to do?
At this point, or as I was healing after surgery?
After surgery.
After surgery.
Sort of post-op.
Post-op, it was a little rough for a while. The drains were the hardest part of my recovery. Dr. B had to come to my rescue and remove the drains a little early. Other than that, I was very fortunate with recovery, though.
Dr. B, to talk a little bit about that, right? I've seen infection, I've seen dehiscence, right? It starts to come apart. I've seen drains. Sometimes it's a little bumpy, right? How common is it that it's bumpy, and what are the common bumps as you go through that part of a surgery?
So I would say that having minor nuisances, or I don't even want to call them complications because they're expected bumps in the road, is fairly common. So some women get some swelling or bruising or discomfort. Major complications, fortunately, nowadays are very, very rare. And a lot of that has to do with patient selection too. So, we're very astute at looking at people's other medical problems, looking at their risk factors before putting them through a major operation that may not be in their best interest. And so in Kaylee's case, she was young and healthy and 30 years old and not a smoker and not diabetic and not morbidly obese. So all of those things contributed to her good recovery.
Those are, diabetes and obesity and smoking are some things that really can make surgery very challenging as you go through things. And I don't know if everybody understands that.
Yeah.
That's stuff that crosses our mind as we're thinking about, is this going to heal? And if you're a diabetic smoker that is very overweight, it's hard sometimes for wounds to heal, and it can get really complicated.
Certainly. And luckily for breast surgery, because it's really skin and tissue, we're not operating in an organ cavity or a deep space. And so even with those other medical problems, most people do well with it. It's not as invasive as some other types of surgical procedures that we may not want to do in that patient population. So
Kaylee, as you go through, we've chemoed you, your hair's gone, we cut out a chunk of your boob, and now what's next, right? What's the next thing for you as you're on this breast cancer journey?
Well, the first thing was when Dr. B called to say, the cancer's gone. We got it all. The margins were clear.
Yes.
And it was the best day ever. After that, we moved on to radiation after I healed.
And that healing, couple weeks, couple months, how long of a time frame is that before you get started?
My surgery was in November of that year, and I began radiation in February.
Okay. And tell me a little bit about the radiation
I had
process.
30 rounds of radiation, 5 days a week. Radiation was really tough on me, even more so than the chemo. I got burned very badly. Had a lot of issues with radiation, painful, but it was all part of it.
As you were going through that painful part, what are some of the Band-Aids, right? What are some of the medicines, some of the things that help? So if there's someone else out there that's struggling with this, what would you suggest?
One thing, they did prescribe a cream for me at the time. I'm sorry, it's skipping my mind. I can't remember what it was. It did help a little bit, but just keeping everything as clean and dry as you could. Obviously not using deodorant, things like that in that area, in the affected area. Wear loose-fitting clothes, that kind of thing. Things you wouldn't think about normally.
Yeah. And Dr. B, any other things as you look back over the sort of radiation experience that people go through?
Yeah, so there's multiple different topical agents that are used depending on the side effects that the patients are having, and that is often helpful. Since Kaylee has been treated, we've kind of changed the way we do radiation therapy in breast cancer patients, and so some of the side effects that she experienced, while not 100% eliminated, are fewer and far between than they were when she had treatment. So
Is that a more narrow beam, or what's some of the,
yeah, so
let's not get
decreased.
sciencey, but what's the basic sort of concept of
So
that part?
decreased number of treatments. So the cumulative effects, radiation side effects are cumulative, and so often women feel great for the first 10 treatments, and then as those side effects start to really take their toll on the skin later in the course. And so by decreasing the treatment course, the length of treatment and the number of treatments that they're getting, we're able to decrease some of the side effects. There's lots of studies with radiation therapy. There's some centers are doing hypofractionated radiation therapy, so they get increased dose but only in 5 treatments, and none of this has become standard of care yet, but there's definitely studies in the works. So
It's one of the things is I look into a lot of different aspects of medicine, right? I'm just turning 50 and I feel old all of a sudden, right? So my health suddenly becomes important. There is so much information out there, and I don't even know if I want to call it cutting edge stuff, but it's kind of on the edge technology that this big giant boat that is medicine moves and turns so slowly with evidence-based medicine, right? It's a complicated thing. Is any of the stuff that you're talking about with treatments and radiation so on the edge that we're not quite even doing it unless it's a specialized center?
some of it, yes. So some of it is relegated to specialized centers. Some of it is still under investigation, so they're actively doing trials. And some of it is very close to becoming a standard of care or widely practiced. Obviously, the bigger university systems have more involvement in the clinical trials, and so now that Finger Lakes Health is part of University of Rochester, we're certainly hoping to get involved in some of that. We haven't yet, but it's relatively new in our journey with them. So
Yeah, it's a great partnership, right? And I think like any partnership, we're trying to figure out how do we help one another, essentially help more people like Kaylee, right? Kaylee, talk a little bit about you get a little teary like me at times, and me too. What's that emotional journey? I mean, it's not one identity change, right? There's multiple identity changes and bumps over a 8-month, 9-month period of time, and then how do you bounce through a bad day emotionally, right?
It's a roller coaster. It really is. Everything about life changes. The way you look at everyday life changes. It's a fear that doesn't ever go away. And it's just something that you have to look back and be thankful for and say, I made it through. I was lucky enough to be this healthy, to be here today. You get through it.
Is there any technique that you used, right? Was your husband great? Was your dad great? How did you get out of bed on a bad morning when you're like, geez, I'm supposed to go to work and my boob hurts and I don't have hair and how am I gonna do this, right? What was the thing that you did on that really bad day to kind of push you through?
My oncologist told me from day one, you need to continue to live your normal life. And I did. My husband and I went to concerts. We went on trips. My dad and I hung out every day. My dad has gotten me through most things in my entire life. And he got me through it. He really did. My husband and my father never left my side through it.
It's the support network is
For sure.
friends, family, counselors, clergy, right? The list of people is endless. Is that experience pretty normal, Dr. B, as you have other patients that go through this?
I do. And, I think Kaylee's experience with her support system was extraordinary. I mean, the way that her family and friends rallied around this person is a testament to the person that she is. And she's not lying. When she came to my office for initial consultation, we had to spill into the hallway because there wasn't enough room in the exam room for everybody to be in there. And the bond that this woman has with those, and it's obviously because of her personality. I mean, I bonded with her the second I met her. People just fell in love with her, and her family, obviously blessed to be in her presence and to see the support and the rallying behind her and the encouraging her. I wish every patient had that, because in the end, those patients do better. Those patients that have a faith and a good support system and a life outside of their diagnosis do better.
There's, on some of my other conversations with people, I've talked about a book called The Good Life. And it's a book written about the Harvard Health Study, right? And the Harvard Health Study is a prospective study where they have looked at people since before World War II that went to Harvard and their surrounding families. And there's one thing that is statistically significantly different, and it's relationships. It's friends and family. And so they watched people go through breast cancer with nobody, and they watched people go through breast cancer with a support system like you've had. And the people with a big support system do better, right? And it's when I don't know, when I trained, that stuff didn't come up, right? We never talked about the support system when I trained 20 years ago, right? And I think it's getting a little more common now. In your training, you're much younger than I am, Dr. B. In your training, did they talk about that at all as you went through things?
Not necessarily. As a medical student, I took some elective courses on, mind, body, spirit connection. I was very involved in a group called the Healer's Art when I was in medical school that sort of focused on seeing a patient as a whole person and taking into consideration their support system and their hobbies and their interests and what makes their life worth living. Because I think that's important. Any journey with cancer, but particularly breast cancer, can be so daunting. And so to have people around you whose sole purpose is to lift you up when you're down and who are just rallying behind you, it's so important. And I think as a society and as healthcare practitioners, we're recognizing that more and more as time goes on. But I agree, 30 years ago, if you asked a surgeon to sit down and talk about the hobbies of the patient that they're about to operate on, you would have been laughed at.
So some surgeons and some of the ones that I trained with, direct might be an understatement, right?
Yes,
It is a very direct conversation, and I don't want to say that surgery is cut and dry, but it's technical, right? And I think some surgeons' personality is that technical personality.
Mm-hmm. And there's nothing wrong with that.
No, there isn't.
You want a competent surgeon.
Yeah. As I said earlier, you don't want me cutting anything. I'm a nice guy, but I'm going to screw it up. I'm not good with my hands. What were some of the things you learned, Kaylee? We're 7 years past this. What are some of the things that you learned through this really traumatic time that might have made you a little bit better version of yourself today compared to 7 years ago?
You learn a lot about yourself when you're going through something like this. You learn that you are stronger than you ever thought you could be. You don't have a choice. It's what you have to do. Life isn't promised to any of us, and it can be taken away in an instant. And you just have to live every day like it's your last and be thankful for the people around you, everything that you have.
Such a great attitude. Do you hear that a lot? Because sometimes when I have people go through what Kaylee's going through, there's an anger, there's a why me, I'm so mad at the world, right? Do you have more like Kaylee, would you say, as you go through that, or is anger a big piece of this sometimes?
I think with anyone who has a breast cancer diagnosis, they go through the stages, right? So it's just like the stages of grief. There's denial, and there's anger, and there's bargaining, and obviously every patient's different. I think most of them come out on the other side and can look back and say, obviously I wouldn't have chosen to go through that, but it gives them a new appreciation for the life that they have. Again, there's a lot of stigma in the media and on social media about breast cancer. And people hear the words breast cancer and they automatically think, I'm going to die. And so I think when most patients come to that initial visit, whether it's with me or with an oncologist or with their primary care physician, that is the overwhelming thought in their head, I'm going to die. And once that fear is alleviated and they're reassured that what they have can be treated and that they're going to be sitting in that chair 6 months or 12 months or 6 years from now, I think some of that goes away very quickly. So for most patients, I think the most anxiety provoking and anger provoking part of their breast cancer journey is that time period between diagnosis and what is my plan to treat this. I can't tell you how many patients come to the office and the first thing they say out of their mouth, when I first meet them, is, I'm so nervous, I'm so anxious, I'm so scared. And they leave the appointment with a smile on their face. I'm glad we have a plan. I feel so much better.
I think that plan is a big part of all of our journeys, right? Whatever the bump is, physical, emotional, cancer, heart attack, right? Having a plan to get through it, I think helps us feel more comfortable. Did you have some of that anger initially, Kaylee?
Absolutely. She could not be more correct. You get very angry. Why me? I'm 30 years old. This shouldn't be happening. Shouldn't be happening to anybody. Well, yeah.
How do you get through that?
Again, my support system.
Yeah.
That's been 100% the biggest part of my cancer journey. I have grown my support system since the beginning of it. One of my best friends, two of my best friends, I should say, my soul sister, she found me through my cancer journey. She had just gone through it herself previously, and she's one of my best friends in the world. She walked me through all of it.
And you met her through cancer, so to speak.
She had read about my story on social media, and she reached out to me, and that changed my life.
How great is that? And this is 7 years ago, and you're still friends now.
Yes, 100%.
Is that common, Dr. B?
For patients to reach out to each other, I think in a subset of women it is. And again, there's sort of a two pathways. There's I'm a very private person and I don't want to publicize my journey and I just want this treatment to be over with so I can move on with my life. And then there's some people who view it as an opportunity to better themselves and to better their community and to really share themselves out of a place of love and out of a place of having been there. And no one can tell you what it's like to be a breast cancer patient or a breast cancer survivor like a breast cancer patient or a breast cancer survivor. And so it definitely brings out the best in some people.
As a primary care guy, right? When I hear breast cancer, I'm like, we got this, right? We got this, piece of cake, no big deal, right? When I hear pancreatic cancer, I'm going, oh my God, we might not have this, right? It's a whole different thing for me. I'm a boy, right? So it's a completely different thing when we think that way, right? And sometimes I think maybe I jump to conclusions too quickly, right? And we don't appreciate the journey that it is, even though a lot of the times we end up okay on the other end of the journey. It's still not the greatest journey, right? And I think I miss that sometimes, right? When you're talking to people,
Right.
especially when you get rushed and people are stacking up and yeah, it happens. What would you guys say to somebody else? Kaylee, somebody going through this, right? What would you say to them?
You have to be your own best advocate, number one. Also, you have to trust your care team. And if you don't, find another care team. Always get a second opinion if you're not confident with that. Luckily, I never had to do that. I was so blessed from day one with that. But you have to stay positive. You can come out on the other side of this.
What are your thoughts about that, Dr. B? What are the things that people experience?
I agree with Kaylee's words 100%. And, I tell every patient, you have to be comfortable with your care team. There's no egos in breast cancer. If you and I are not a good fit, please go somewhere else. I'll give you names. If you get 5 opinions before you find the person that you're comfortable with, please do it, because this is a journey that you're going to be on for the rest of your life. And at least in my practice, I follow my breast cancer patients for life. So I do all of their breast health from the time they're diagnosed until the time they get sick of me. And so you really need to be on the same page with your healthcare providers, with your oncologist, with your radiation oncologist, with your surgeon, with your primary care physician. I am not the be all end all. There's many breast surgeons in the greater Rochester, Syracuse area, and certainly same thing with oncologists. And you just have to trust your healthcare team, and you have to be okay with not being okay sometimes.
I think a lot of us that do what you and I do get where we are with a little bit of that ego, right? We get where we are by working hard, and I'm a little bit better than this other guy, right? And it's not right, right? And some of us don't ever want to let go. Why didn't you pick me? At the end of the day, I couldn't agree more, right? You got to be comfortable with your care team. And if you're not comfortable, find someone else. If you got that pit in your stomach because someone was too crass or too quick, or you didn't like the environment that you were in, go look someplace else before you pick that person that's going to be hopefully with you for the rest of your life. What else, Kaylee? What else do you want to share?
I have, my husband and I adopted our daughter 4 years ago. And I truly believe that that little girl is the reason I went through everything I did. The day that I met my oncologist, right after I was diagnosed, I had to make a choice to either freeze my eggs or start chemo. I knew what I had to do. It was the hardest decision I've ever had to make in my life. I had to go home and tell my husband, this is what I have to do. And now here we are, 7 years later, with this beautiful, perfect 4-year-old crazy little girl. Oh, my father tells me every day that kid was meant to be yours. She's amazing, and she's my reason for everything now.
It's funny how life changes that way, right? Talk about that, Dr. B, right? So these aren't, do you want mashed potatoes or rice questions that at this tremendously challenging time of your life, you have to make a decision for a lifetime, right? How hard is that as you chat with women about this?
I can't speak to how difficult it is because I have not been through it. But obviously, as a woman and as a mother and as watching my patients go through this, I cannot even begin to imagine the heartache that causes. And there's all different scenarios. There's women who get diagnosed with breast cancer while they're pregnant. There's women who get diagnosed with breast cancer while they're nursing, and all of these decisions that need to be made. So I can't even begin to pretend to understand how that makes you feel. But there are options, and there are options in 2024 that there weren't necessarily in 2000. So, constantly evolving field of medicine. I think we're much more focused on fertility preservation than we have been in the last 10 or 15 years. I'm not an expert in fertility preservation, so I won't even pretend to know all those options, but I know there are options. So
it's, medicine is so vast now, right? Some of the stuff as a primary care guy, right? This receptor, that receptor, positive, negative. Do you want to talk at all about that?
I can speak a little bit about it. So it's a very technical, and so breast cancer, when we when we do a biopsy and we get a breast cancer diagnosis, immediately that biopsy specimen is sent for additional testing. And so we look for estrogen receptors, progesterone receptors, and a protein called HER2. Those are the three big ones. And the reason we look for those proteins is because we have treatment available that we can tailor to the we call it the biomarker profile or the biologic characteristics of that tumor. And so certain types of tumors have a better prognosis. Certain types of tumors have drugs that are really custom made to treat that specific type of tumor. So estrogen and progesterone receptor positive tumors that have those receptors are probably the most common and usually have a much better prognosis than other tumors that don't have estrogen and progesterone receptors. How we treat them depends on whether a patient is premenopausal or postmenopausal. not having any of those receptors, something called triple negative breast cancer, is a much more aggressive form of breast cancer. And we treat triple negative breast cancer kind of like a whole separate entity from all the other breast cancers. And so it's important to know those things ahead of time because it helps us determine appropriate treatment for the patient. It helps us determine appropriate surveillance for the patient. And just keep up in the back of our mind. I can meet a patient and look at their tumor and the biologic characteristics of that tumor and really say, we could probably leave this tumor in your breast for 5 years and it would never bother you. But obviously we're not going to do that versus, the triple negative breast cancer patient who has a 5-centimeter tumor at the time of diagnosis, we don't get that tumor out and this patient will be not here in 6 months. So, as I said earlier, breast cancer is really a catch-all term for a million different diseases and not any one tumor acts or behaves the same way as anybody else's.
It's, and again, when we trained, some of the stuff, it wasn't quite there yet, right? So much more DNA and gene testing. And as I said sort of at the beginning, and I think you alluded to, from the minute I say the C word to the minute that we have a plan of how we're going to attack this thing can be so anxiety provoking. When we talk about all these receptors and genes, what's that time frame in your mind, right? When you poke a needle in a tumor and chip it off, how long would you tell people to expect to wait to get that sort of result back?
It depends on where the biopsy is being done. So in Geneva, we try to have a turnaround time of 5 business days from time of biopsy to time of diagnosis. Sometimes that's 2 days, sometimes it's 7 days, just depending on how many biopsies we're doing. And there's a lot of factors that play into that. And then for me, in my mind, my goal when I meet a patient for the first time is consultation to OR in less than 3 weeks.
That's awesome.
Doesn't always happen because sometimes we need to do additional testing. Sometimes we have to do additional studies. Sometimes the patient isn't ready to make a decision. Sometimes they want to get a second opinion. But I try in my OR schedule to reserve spots for new breast cancer diagnoses so that they are never waiting to have surgery.
That's awesome. Was that kind of your experience as you went through this stuff, Kaylee?
Yeah, I got a fairly quick turnaround with my genetic testing results. And I found out I was HR positive, HER2 negative. I did not have the triple negative, so that was a huge plus for me. It was all good news from there.
I love it. Dr. Baltazar, the people out there, right, this is Breast Cancer Awareness Month, right? And if you had to give a message to someone Kaylee's age or someone 50 or someone 60, what would that message be to kind of the different populations out there?
Well, I think overwhelmingly, get your screening mammography. I mean, there's no doubt about it. Mammograms save lives. So average risk women should begin screening mammography at age 40 as of right now. Those that are considered high risk, so that's anybody who's had a first degree relative, a mother, a sister, a daughter with breast cancer, should begin screening at 10 years before whatever the age of diagnosis was of their relative. So if mom was diagnosed at 40, screening should start at age 30. Within the last 10 years, we've really been able to identify women that are considered high risk. So that high risk category is any woman who has a lifetime risk of developing breast cancer of greater than 20%. And within the last 10 years, insurance companies have been mandated to pay for screening MRI in addition to screening mammography for those high risk women. So that's been a huge change in the way we screen for breast cancer. Traditionally, MRI was never used as a screening tool. It was really used as a diagnostic tool. And so now in women who have that lifetime risk of greater than 20%, we're screening them every 6 months. They're getting an imaging study and a clinical exam, which has dramatically changed the way we're diagnosing breast cancer.
When you talk about, there's a lot of gene studies now, right? And so super high risk women, and there's some even not so popular gene studies where you talk about liquid biopsies and all this fancier stuff that's out there. Is there stuff that you recommend if someone's, geez, my sister had breast cancer at 35, right? Or are there more studies that you would suggest people get?
So I think genetic testing has become a huge, important piece of the puzzle. Traditionally, insurance, again, would only pay for genetic testing in patients who had a very strong family history. Most insurance companies nowadays will pay for genetic testing in any patient who's been diagnosed with breast cancer, which is huge. And so the majority of women who have breast cancer will not have a genetic mutation, but in those that do, it has dramatic implications for the way we treat their cancer. Obviously, if you have a genetic mutation that predisposes you to developing breast cancer, I'm much more likely to recommend more aggressive surgery, more aggressive chemotherapy, more aggressive radiation therapy in that patient population. So it's important to know, but it's also important to know that only 5 to 10% of breast cancers have a genetic mutation associated with them. So most patients that are getting diagnosed with breast cancer don't have an identifiable genetic mutation.
Kaylee, what would you share, to other women going through this?
The same thing. You have to be your own best advocate. Early detection is key. You really just need to be self-aware. Educate yourself. And if you have questions, ask. If you're going through something, reach out. Don't hesitate. We've kind of made it part of our mission as a family to be there for anybody going through this, like my friend was for me.
It's again, the support network is huge, I think, as we move forward. Because I'm a boy, right? Mm-hmm. What was so great about your husband?
He's kind of just awesome most times. We've literally spent half of our lives together.
I love it.
We've been together for 20 years.
I love it.
And at a time when a lot of people probably would have walked away, he didn't. He stayed. And he was by my side through everything. And he still is.
Sounds like a keeper.
Kind of is. He's all right.
Don't let him get a big head.
You ladies always have to keep us in check, right? You're great, but not that great. You're handsome, but not that handsome, right? That's kind of the standard.
Never.
As I was going through it, he was going through it too.
Yeah. It's identity changing for a family, right?
For sure.
All of us go through something and all of us change a little bit. And in what you went through at age 30, you don't predict that's going to happen, right? No one even thinks about it when they're 30. That's a peak, wonderful time of our lives. Any other final thoughts that you guys want to share with anybody as in October, Breast Cancer Awareness Month, before we sort of conclude?
I think the take-home message should be, don't be afraid to ask the question too. If you feel something, if something's not right, if you just have that gut feeling, go see your doctor. I think a lot of women are afraid to ask the question because they don't want to look stupid, because they don't want to know the answer to the question, because they're afraid, because they're unsure. There's a million reasons to not ask the question, but ask the question. And I tell patients, I would rather have you come to my office 100 times and have nothing wrong with you than sit home the one time when there is something wrong with you.
I think as we all go through things, right, we have this gut feeling, right, this instinct that something isn't right? And I would agree, asking the question is super important. Kaylee, anything else you want to share?
Just listen to your body. There are so many resources these days. Again, educate yourself. Never be afraid to learn about it, because it's something that could happen to you.
Ladies, from the bottom of my heart, I can't thank you enough for sharing. Kaylee, these vulnerable moments are so hard to share with the world. And thank you so much for sharing them. And thanks for being a part of the podcast.
Thank you for having us.
Thank you
My
for
pleasure.
having us.